Thank you for the very good analogy and all the steps. There's one other major area that's not getting data captured at the moment. What happens with the doctor's charts, and I've worked in collecting good research data, is that they do not put into aware of that.
I think you're exactly right. I think maybe one of the hidden reasons that I got into this is that I can't even read my own writing. So I tell people now I was advanced, that my records were all encrypted and secure. But I don't think that that's what people really expect. But it's a serious problem that our hospital, because we're so behind in the use of IT, and throughout Canada people are backward in the use of it. It drives a hospital lawyer crazy, because if somebody then goes to the hospital and says, I'd like a copy of my record, where is the record? Is it the record in the hospital? Is it the record that the doctor scribbled on a piece of paper? Is it the record that they keep on their notebook computer? But what's interesting is that people are trying to get information about outcomes, and I think doctors and nurses are beginning to rebel at the whole notion of being kept. Before I came, I had several calls from the media. In New Glasgow and one practice in Toronto, they're planning to implement a primary care cooperative. In a primary care cooperative, and this is my vision of how it would work, but it would be up to the board. So it's not a doctor or nurse or government telling them how to operate. But this is one vision, that the cooperative decides that it needs a set of services. Some of the services that are important that aren't insured right now include information technology in a primary care office, working with primary care nurses, working with other professionals. In this strange health system we have that have a nurse, that have computers, that have the full meal deal. So the patients are saying, let's kick in $10 or $15 a month. We'll use that money to buy the resources that we need. We'll use it to hire and work with primary care nurses, so we don't always have to see a doctor. We'll use those resources so that we can call listen patients, which is about an average practice. That works out to about $360,000, plus about $150,000 or $200,000 of insured billings. That gives the practice $500,000 that the board can decide to spend in ways that benefit their health without having to rely only on government. And presumably then, the doctors would capture the information in a way that they could report back to the board and say, this is what we accomplished. The nice thing about it is, if the patients don't like the care they're getting, then they can leave. And when they leave, they take their $15 a month with them. So there's some benefit to actually satisfying people, which almost seems like a novel idea in this peculiar health system we have. I hate to be the bearer of, I know this news is somewhat bad news, but I'm sorry for that.
I have another question about, are you still using the additional information that you were collecting in Halifax then about some of the lab results still on your chart?
No. This is the other piece that's very interesting, and one of the things that led to the co-ops. In Canada, we were speaking about this at lunch, in Canada, if you create tools that are valuable, that patients like, it doesn't necessarily mean that they'll continue. So one of the projects, the one you're talking about is Metascoops, which was one that allowed you to measure outcomes. It captured information about adverse reactions. When we used it in Halifax, it saved our patients in two ways. One is we found that there were a group of people who were getting blood products who shouldn't get blood products because they had normal or higher hemoglobins, and there were a group of doctors who were using them inappropriately. So we told them and they stopped. The other way it saved us is, and it didn't save a group in British Columbia who had the same problem but weren't using a system to monitor outcomes and monitor health status. We got a new lab system. One day the health record reviewer came to me and said, David, what's going on in our hospital? Suddenly the patients on the medicine service seem not to be very sick. And the way the system attributed illness was it took objective lab findings. So if your hemoglobin was low, if your blood sugar was high, if your electrolytes were abnormal. And it took as many as 300 abnormal findings. They said, it's harder to get for people to get into hospital, but the patients don't look sick anymore. And it turned out that the lab system wasn't reporting a large number of abnormal results. The doctors weren't getting it. We picked that up within a week. So I think it's very vital to have this real-time concurrent screening so that you can change things as they're happening. It's not a matter of identifying error after it's happened. It's a matter of identifying error and bad practice and things that are likely to be harmful while you're doing it. We don't want somebody to come back and say, the pilot did this, the plane crashed. We want a red light to go on and say, guess what? You're about to crash the plane. Don't do what you're doing. But in healthcare, we've abandoned those. So our idea is that since patients benefit, but governments seem not to think that they do, that maybe if patients had more control over how the money was spent, we'd be able to have systems that work better. And when we presented this idea to a group of people at a senior citizens home, they asked, does that mean we'll be able to give less money to governments to spend on our behalf? Which raised a whole other, I said, that's a separate negotiation.
I was just wondering, sometimes with, you'd mentioned, adding separate assessments like the McGill and in some of my experience, like the minimum data set and things like that, to capture extra outcomes. So a lot of that information is best collected by frontline people, but at the same time they're averse to collecting it because it means more paperwork on top of the chart, and they want to focus more on direct care. Do you have any suggestions about getting around that adversity? Or?
Yeah, I think there are several ways to do it. One is, if you penalize people for capturing data, then they won't capture data. We find it now with the big dispute about physician order entry. Somebody has said to doctors, now we'd like you to enter the orders. And the doctors are saying, no, I'm spending 10 hours a day at the hospital. I won't spend 11 hours. So somehow you have to find an offsetting benefit that will enable them to do it. But one way to do it, I think, we don't have to capture this information on every patient systematically. We could do it on a sampling basis. Why can't we work out a statistical model where for every certain number of patients, the doctor gets a prompt and then does a complete evaluation and perhaps gets paid for it in this crazy system where doctors are paid piecework, or in another system where if they were paid in a different way, they probably would be happier to do it. So I don't know if that's helpful in an environment where it's very difficult to make change in how we do things. Doctors, by the way, are happy to have rigorous information. When we gave people information that they were harming patients by inappropriate blood products, nobody said, Zitner, you're an idiot. What they don't like is, they should have said it, but maybe for other reasons. What they don't like is to get misleading information. In Nova Scotia, there was a doctor, Sandy McLean, who doesn't mind if I tell the story. He's left Nova Scotia. But government came to him and said, Dr. McLean, what's wrong with you? You prescribe more drugs to old people than everyone in the province. Your prescribing is the highest. He said, well, the patients are getting drugs appropriately. So it turned out that he basically only looked after old sick people. So if you only look after old sick people and somebody else looks after teenagers, you're going to be giving more drugs to old people. So eventually they said they wanted him to give back $40,000. So finally they looked at it and they agreed that he was not only not ripping off the system and being casual, but they agreed that he was a terrific doctor. But by the time they agreed he was a terrific doctor, he said, guess what, I'm out of here. And I think what people don't like is to get information with bad denominators. One of the things that got me into doing some of this work is when I chaired that utilization committee, I saw some data that said, there were two doctors in particular who were international authorities, one in respiratory disease, one in endocrinology. I looked at the reports we got from CIHI. They said that me and some of my colleagues were better at treating diabetics than they were, better at treating pneumonia. And I knew that I was asking them for advice. And what it was is that all of the patients who were really sick were on their dime, and all the patients who weren't so sick, and in fact probably for me, some who may not even have had to be in hospital, were on my dime. So of course, if you admit somebody who's not so sick, they're going to have a better result than somebody who's really sick. So I think this notion that doctors don't like information is wrong. And you've had experience. What do you think? If you give them reliable information?
Well, I think, and actually it's interesting that they do want reliable information and they work very hard. I have a lot of physicians who actually now participate at CMHI on some of the panel groups, and we've actually got changes to CMGs. But we spend a lot of time working with the physicians and the nurses to say, if there's something wrong with the patient, you really need to capture it, because if they've got congestive heart failure and diabetes, and it really influenced all the drugs you provided them with during the valve surgery, you got to tell us that, because they get so wrapped up in the practice. And there's some studies now in Ontario where they're actually having the nurses document on a front sheet, but because of the CIHI rules, then the physician has to check mark and initial if they agree with that, so they can pick up the comorbid conditions. Because some of your friends at Mount Sinai played it to the max and caused, like, if you're having a hip replacement, yeah, you have some problems walking. So that's not really a complication. So they kind of went in.
Whatever, I mean. But I think the only point of telling the story wasn't to... What CIHI said is that they felt that even if people played by the rules, they might still be gaming the system. And I don't know what that means. That if you play by the rules and you're still gaming the system, it means the rules aren't too good. So you really need to have a set of rules that work. But in any case, if the information is misleading, which people don't disagree. In fact, CIHI came out a year and a half ago and said, you can't use the information to compare hospitals. You can't use the information to compare your own performance year over year. And then people use it. Then it isn't surprising. But it still begs the question of, did people get better or worse? And for the life of me, I don't know why we don't capture from the nursing notes comfort and function, because they recorded every single day. Are there any nurses in the room? Okay, so you record, so you know what your colleagues do, right? They say, Mrs. Jones had a pain in her foot. This is how severe it is. Mrs. Jones wasn't walking, now they're walking. It's like not that complicated. And some of the people in healthcare say it's impossible to measure outcomes. But every patient knows if they're better or worse. So if every patient knows if they're better or worse, why can't we just ask them, are you better or worse? That would even be a small start.
I want to be clear on one thing before I leave, and that is perhaps a statement that you can respond to.
Yes.
Is it your belief, then, that Canadian healthcare delivery system should be a government monopoly?
I think that Canadian healthcare, I think that a system where we have universal insurance is terrific. I don't think that the government should be... The reason we tweaked to this notion of this conflict of interest, Bill 34 in Nova Scotia said that government is required to insure, administer, regulate, and evaluate health services delivery. I don't think anybody should be in the position of having to regulate their own performance. My daughter, when I mentioned it to her, she's a student at Concordia, she said to me, Dad, I sort of get it. That's like if I went to Concordia and they said to me, you decide what you're going to read, you decide whether you've read it, then make up some questions that you want to answer yourself, and then give yourself a grade. Well, that doesn't make sense, even if people are honest and straightforward. So I think that we need to strengthen government's role as a regulator. I think that some of the things that happen in healthcare are really bizarre and abhorrent. And I think some of the things that aren't appropriate are the way we treat nurses, for example. Some of the shift work that people, maybe it's better in Ontario, but I know that in some places it's horrible. They have shifts that are ridiculous. In Nova Scotia, we have some doctors who every 7th week work 168 hours a week. So 7 times 24, multiply it out. They work the whole week in a serious type of activity. Government as a regulator wouldn't accept it. I just was on a flight from from Vancouver to Halifax. We stopped in Montreal to change planes. The plane from Toronto that I was supposed to get on was delayed, and they said it would be there shortly. It arrived at 10 o'clock. At 10 o'clock, they said to us, the good news is that the delayed flight from Toronto has arrived. The bad news is that the pilots have used up their allowable hours, so you can't get on the plane. So I think the reason that we tolerate it is that governments the waiting times in emergency departments. The other piece that I think is bizarre is a piece about the waiting time in emergency departments, where you have people waiting hours, sometimes 15 or 16 hours. Government wouldn't tolerate. And if you think about uninsured people in the States, the American Medical Association complained that 15% of Americans can't get health care. In Canada, as many as 20% of people can't get a family doctor. So if an independent insurance company said, we're going to capture your premiums, but you can't get the services, government would say, fix up your act. So I think government needs to have this is a personal opinion, so I think government should be strong as a regulator. I think strong as an insurer. I think Kirby, Romano, definitely not the Romano. Everybody says we need to have catastrophic drug coverage. So I think I would rather see us all pay a little bit if we can afford it and make sure that nobody goes without for the expensive stuff. Does it make sense to have somebody wait? In Ontario, people are waiting for surgeries, or waiting for cancer care. Does it make sense to take communal money and use that to pay for ordinary doctor visits that most of us can pay for, and let sick people suffer? That you only get top quality care if you have plane fare to Detroit. So I think that's my opinion. But
there is some good news in our data collection in Ontario, because to build on his comment about chronic care, our rehab data set that was it actually measures function of care. And so we could actually show that we're keeping our patients at my site longer, but they have a 60% greater increase in their function of care when they leave, or their functional outcome. So using FIM scores, I mean, it was really nice to see data sets that are meaningful, and I think the clinicians really appreciate that kind of information, and then they can also use that to say that we need more rehabilitation beds or whatever. But you have to kind of capture the information so you can prove your point, and I think that's what we've really tried to do in Ontario.
This really is a good news story, that CIHI actually, for rehab patients, does capture information about function. One of the people who, a pediatric nephrologist, he got criticized. His length of stay for children after renal transplant was the longest in the country. But his death rate was 50% lower. And what he did is he kept people in the hospital, I think for as long as 2 months, and monitored them for signs and symptoms that would predict that they were going to have problems. So again, he was severely criticized. But when you had the outcome data to support the resource use, it became valuable and even rational. Because what's the good of being in hospital for 1 minute and then 10% of people die? It's better to be in hospital for 3 months and no percent die, or whatever. I mean, but you need the data to reach a conclusion.
Questions or comments?
I have a kind of simple question about context, and that's, so there's many healthcare systems around the world. Who's collecting data well, and what are they doing to do it?
That's a good question. The question was, is anybody collecting data well? I think that there's some systems that are beginning to. I think Sweden, which has a mixture of public and private, where they have public insurance, but they contract some of the services out to the private sector. They demand that people give some performance reports. But I think it is spotty across the whole healthcare sector. Maybe somebody else knows an area that's doing it really well. In Britain, they're beginning to collect process measures, but that's not really the important piece, so that they're looking for primary care at the number of, the proportion of a practice that's had a pap smear. But really the important question is, what proportion of a practice gets cervical cancer? Because some people are at very low risk. So if somebody is, 45 and has been celibate all their life and isn't at risk of cervical cancer, why should they get a pap smear on a regular basis?
Two examples, I showed to St. John. Two examples would be the SEER database in the U.S., and I think the BP healthcare is very monitored, and it has outcome, quality control and the assessment, especially in the cancer area. So in the cancer area, which is a costly one, it's highly developed.
And I think the other area that's developed is cardiology, where people stratify patients by risk. But the cardiologists have done a terrific job of saying, if you have certain characteristics, how likely are you to die if you wait a certain period for treatment and not for others? And I think that's a model that probably could be incorporated for other conditions as well. You're familiar with it? Or do people know about it? People are working with it?
Other questions or comments? David?
With a system as large and complex as the present Canadian healthcare scene, it's pretty clear that even if, as a society, we decided tomorrow that we wanted to capture outcome measurements, it wouldn't happen immediately. I think it would be more likely to become desirable if there was some kind of demonstration project in an area where there was the potential for clear demonstration of benefit.
Well, let me run a proposition by you.
Pardon?
Let me run or are you finished your question?
No? But yes,
no,
you're going to answer my question, so go ahead.
Well, maybe it's a different question, but tell me anyway. If you consider small practices, if you consider a community that has 3 different medical practices, and people actually had a choice of which practice to go to. And one practice said, we have terrific results, these are our results. And the other practice said, we don't have a clue. Which practice would you be likely to go to? So I think when we try and do it on a whole system basis, we may actually run into trouble. If you consider Walmart, some of the retail industry, they've succeeded at forming networks. They've succeeded at capturing very valuable information to allow them to provide goods and services. But in order to do that, each of their stores had to function. Right? Walmart didn't suddenly have whatever in 10,000 stores and then said, let's connect them. They said, we have these stores that are working, this store that's working, this store that's working. So I think if you try and do it on a whole system level, it may be very difficult, because different communities will have different needs. But I think once some people start to do it, and once people have a choice, some of you in the room probably don't have a family doctor, and you probably don't have a choice of family doctor. And some of you, with the number of people in this room, I'm sure that some of you have a family doctor that you don't like. And some of you don't know whether you should like your family doctor or not. You think they're a terrific, great person, but you don't know if the advice they're giving you is really great advice or off-the-cuff advice or guesses. So I think if people had a choice and were able to get some precise information, then there would be an incentive to do it. Right now, there's no incentive. I haven't heard in any of the discussion around healthcare in Canada, not a single party has come out and said, these are the results of healthcare. They all say, we want to make it better, we're going to reduce waiting lists. Are we going to reduce waiting lists for necessary care or for unnecessary care? Are we going to make it so that people who are 50 will get colonoscopy screening even if they don't have risk factors and they don't need it? How are we going to follow the results? So I think there is a hope to do it, but I think it's going to have to start on a small scale, as some people are starting and trying to do.
David, what about another problem? For example, when you told about this doctor who was practically punished for taking care of his older population, what about if we gather all the data and information that we want, and we will get in a situation when we're just overloaded by this information, because what exactly it says, we don't know. Because, I mean, how to make sure that next time something would happen to this doctor who was caring for geriatric population would never happen again?
Well, I think one of the ways to make sure it doesn't happen again is for the people who are using the information to know something about information, which is why people like Dominic, people at other universities are trying to have some health informatics programs, and why there are programs in epidemiology, community health, that basically, if you want to look at a rate, you have to have a numerator and a denominator. That to say that a doctor does a certain amount of X without saying, so what does it mean? But it's true that people may misuse the information again. And again, part of the reason, I think, somebody sent me an email yesterday. They said that healthcare is the only area of our economy where failure is rewarded. So as the waiting list became longer, we put more money into it. As the results get worse, we put more money into it. Whatever happens, we put more money into it. Any other industry, if you fail, people say, well, I'm not giving them money. They threw out my last dollar. So I think that you need to have some model where government can actually function as a regulator, where government isn't the one who says to the person, you're prescribing too many drugs, and if you prescribe fewer drugs, we're going to save money ourselves. So I think that there's a serious structural problem. So I think until we can, I think it will happen again unless we deal with the structural issue. And the structural issue is that there's a conflict of interest. Communities have to decide, do they want governments? I think we all want government to be an insurer. So now do we want them to be an administrator or an evaluator? I don't think they can be both. So if we decide that we want them to administer care, then we need to have a separate, sophisticated group like the Auditor General reporting on care on a regular basis. Now, Michael Dechter, who's the chair of the Health Council, he wrote an article before the Health Council was formed, and he said he was afraid that the Health Council would become a paper tiger, and he didn't want it to happen. Well, it may be a paper tiger, because the people on the Health Council are by and large people appointed by the ministries and deputies of health, the very people whose performance is being assessed and reported on. So again, I think unless we deal with the structural problem, there's not going to be an incentive to capture outcomes. You've been trying to capture outcomes as long as I have, 10 years probably, right? And nobody says you're full of beans, don't do it. Everyone says it's a great idea, but let's collect length of stay by diagnosis instead, except for the thin.
Just maybe one quick question, David, is you have been yelling about this for a long time, and I think you've... That's right, getting hoarse. I think you recognized that CIHI had begun responding to this. And yet, if they do respond, they're probably the wrong agency because of what you've just said. You know, what is the future if you're the voice in the wilderness, and what is the future that would be a good future that you see? What's the solution?
Well, we're trying to have a solution where the patients have more power and control. So one of the solutions is that if people, as citizens, understand the environment and start asking the questions and hold those delivering and administering care responsible, then we may see what we need. But I think until that happens, we may be doomed. I may be doomed to have to become very hoarse.
Well, thank you very much for
my pleasure.
The presentation, and we really thoroughly enjoyed it.
My pleasure.